Welcome to the Hospital Medicine Unplugged podcast.
Thank you. It's great to be diving into this material today.
Yeah, absolutely. So I want you, the listener, to imagine a specific scenario. You're reviewing a bone marrow biopsy report for a 72-year-old patient you just admitted to the inpatient wards.
Right, a very common admission.
Exactly. And this patient presented with profound, highly symptomatic peripheral pancytopenia. I mean, we are talking about a hemoglobin of 6.5 grams per deciliter.
Which is critically low.
Right. A platelet count of just 20,000 per microliter and an absolute neutrophil count hovering right around 0.4 thousand per microliter.
So high risk for spontaneous bleeding and opportunistic infections.
Exactly. Now, given that totally empty peripheral blood smear, you might instinctively anticipate seeing an empty aplastic marrow on the biopsy.
You'd think so. Yeah.
But instead, the pathologist describes a bone marrow that is 90% cellular.
Wow.
Right? It's hyperactive. It's just teeming with precursor cells, yet the peripheral circulation remains dangerously devoid of mature functional cells.
And that right there is the fundamental paradox of the disease.
It is. So today, we are undertaking a rigorous clinical deep dive into this exact paradox. We're looking at the rapidly evolving, incredibly complex landscape of myelodysplastic syndromes.
Yes, and the landscape has completely shifted recently.
It really has. Our objective today is to provide you, the practicing physician, with a comprehensive clinical update. And this is grounded directly in the latest National Comprehensive Cancer Network guidelines.
Specifically, we're looking at version 3.0 for 2026.
Right, alongside the really critical structural updates introduced by the World Health Organization in their 2022 classification.
Which fundamentally rewrote the rules.
It did. Because as you consider this diagnosis in your daily practice, you have to recognize that the foundational approach to myelodysplastic syndromes has undergone a massive paradigm shift.
A total shift. Historically, this condition was defined almost exclusively under the microscope.
Right. We relied on the morphologic evaluation of bone marrow aspirates and biopsies.
Exactly. We were looking for visual dysplastic changes, things like ring cytoblasts or nuclear budding. But today, that purely morphologic approach is entirely obsolete.
It's gone.
Yeah, that historical reliance on morphology has been definitively supplanted. The diagnostic framework has firmly transitioned into the realm of complex molecular and genomic profiling.
Which means we have to think differently on the wards.
Precisely. The clinical reality you face today is that the management of myelodysplastic syndromes requires an exhaustive understanding of the underlying genetic architecture that's actually driving the disease.
Because to properly manage a disease, you obviously have to first accurately define it.
Right. And that definition has been radically rewritten. The World Health Organization 2022 classification update represents a profound shift toward incorporating highly specific genetic features alongside, and honestly often superseding, traditional morphology.
Superseding being the key word there.
Exactly. The system now formally recognizes genetically defined categories of myelodysplastic syndromes that completely override standard morphologic descriptions.
So the genetics trump the visual appearance.
Yes. This shift acknowledges a really fundamental biologic truth. The molecular etiology of the disease is a far, far more accurate predictor of clinical behavior, disease trajectory, and treatment response than the mere visual appearance of those cells on a glass slide.
Let's unpack those specific genetic classifications, because understanding them it's no longer strictly the domain of the hematopathologist.
No, not at all.
It directly impacts how you will counsel and manage your patient. The World Health Organization now delineates distinct clinical entities based on single-driver mutations or specific cytogenetic aberrations.
Which gives us very specific targets.
Right. For instance, we have the category of myelodysplastic syndromes with SF3B1 mutation.
And that one is fascinating from a mechanistic standpoint.
It is. When you see this mutation on a report, you are looking at a fundamental defect in the cellular spliceosome machinery. The SF3B1 gene is responsible for RNA splicing.
Right.
And when it's mutated, it leads to the aberrant splicing of downstream targets that are specifically involved in iron metabolism and mitochondrial function.
Which directly translates to what we used to look for under the microscope.
Exactly. This is the precise molecular mechanism that clinically manifests as the classic ring sideroblast we used to rely on for diagnosis.
So we now define it by the root cause, not the visual symptom.
Precisely. We also have the distinct category of myelodysplastic syndromes with isolated deletion of the long arm of chromosome 5 or isolated del5q.
A very classic presentation.
Right. And this is not just a random chromosomal loss. It results in the haploinsufficiency of specific ribosomal proteins,
which triggers a cascade.
right, which in turn activates the p53 pathway, leading to profound erythroid hypoplasia and a very distinct clinical phenotype.
And that phenotype has historically shown unique sensitivity to specific targeted agents, like lenalidomide.
Exactly.
So understanding those specific mechanisms is crucial. However, I want to pivot to the most critical and highly specific new category introduced by the World Health Organization.
The TP53 category.
Yes, myelodysplastic syndromes with biallelic TP53 mutation. This category demands intense clinical attention from you, the provider, due to its profoundly aggressive nature.
It's basically a completely different disease biologically.
It really is. The definitional criteria for this entity are exceptionally strict.
Right. It's not just any TP53 mutation.
No. It requires the presence of a variant allele frequency of greater than or equal to 50%, or the presence of more than one distinct TP53 mutation, or a specific TP53 locus abnormality, such as a concurrent chromosomal deletion.
And the TP53 gene, as we all know from basic oncology, is the master tumor suppressor.
The guardian of the genome.
Right. It's responsible for initiating cellular apoptosis in the presence of severe DNA damage.
Exactly. When a patient loses just one allele of TP53, the remaining functional allele can actually often maintain a degree of genomic stability.
It compensates.
Yes. However, when we identify a biallelic loss, meaning both copies of the gene are mutated, deleted, or otherwise silenced, the cell entirely loses its ability to undergo programmed cell death in response to genomic errors.
Wait, let me clarify that concept of variant allele frequency for a moment, because it frequently appears on our molecular pathology reports and can be confusing.
It's a vital concept to grasp.
Right. When we talk about a variant allele frequency, or VAF, of greater than or equal to 50%, we aren't just looking at a minor subclonal genetic hiccup in the background.
No, we are saying that at least half of the DNA sequencing reads at that specific locus in the sampled marrow are mutated.
Right. In a typical heterozygous mutation, where one allele is mutated and the other is wild type, you expect a variant allele frequency of roughly 40 to 50%, assuming the entire sample is comprised of tumor cells.
Assuming 100% tumor burden, yes.
Right. Therefore, when you see a variant allele frequency approaching or exceeding 50%, it strongly implies a loss of heterozygosity.
Meaning the wild-type allele has been entirely deleted.
Exactly, leaving only the mutated version. It indicates that the mutation is profoundly entrenched, driving a state of rapid, unchecked clonal expansion and massive chromosomal shattering.
And that is precisely the biologic implication. When a patient falls into this biallelic TP53 category, their clinical phenotype is characterized by rampant genomic chaos,
It's incredibly difficult to treat.
profound resistance to standard therapies, and an exceptionally high rate of rapid transformation to acute leukemia.
But we must also address the patients who do not harbor these specific defining genetic lesions, because you will see plenty of them.
Absolutely. For those individuals, the World Health Organization 2022 update has simplified the morphologically defined categories.
So how do we stratify them now?
Well, if a patient lacks the SF3B1 mutation, the isolated del5q, or the biallelic TP53 mutation, we classify them primarily based on their bone marrow blast percentage.
Right, going back to the cell counts.
Yes. We categorize them as having myelodysplastic syndromes with low blasts, or MDS-LB, when blasts are strictly less than 5%.
Okay.
As the disease accelerates and the blast count increases, we move into myelodysplastic syndromes with increased blasts 1, or MDS-IB1. That's defined strictly by a blast percentage of 5 to 9% in the marrow.
And then it goes higher.
Right. When the blasts increase further to 10 to 19%, we classify the patient as having MDS-IB2.
Got it.
There are also specialized morphologic categories such as MDS hypoplastic, which requires careful, rigorous differentiation from aplastic anemia.
Which can be tricky.
Very tricky. And MDS with fibrosis, which can easily be confused with primary myelofibrosis.
But before we can even stratify patients into those specific blast-based categories, we have to ensure they actually satisfy the absolute baseline diagnostic requirements for the disease.
Right. You can't just skip to the blast count.
Exactly. According to the guidelines, establishing a diagnosis of myelodysplastic syndromes requires the presence of persistent, unexplained cytopenias for 6 months or longer.
It can't just be a transient drop from a viral infection.
Right. It also requires the definitive presence of morphologic dysplasia of greater than 10% in at least one bone marrow lineage.
Meaning greater than 10% of the erythroid, myeloid, or megakaryocytic precursors must demonstrate those abnormal morphologic features.
Which brings us right back to the clinical scenario we opened with the paradox of bone marrow cellularity.
It's a classic presentation.
It is. As a standard clinical heuristic, normal bone marrow cellularity approximates 100 minus the patient's age.
Right, a simple but effective rule.
So a 70-year-old patient should have roughly 30% marrow cellularity, with the remainder composed of fat spaces.
Exactly.
If you see a 70-year-old patient with severe peripheral pancytopenia, but a bone marrow biopsy showing 90% cellularity, you are witnessing the classic defining hallmark of the disease.
That paradox is the absolute pathophysiologic core of the condition. The bone marrow is hypercellular because it is working frantically to produce cells in response to the peripheral cytopenias.
It's trying to compensate.
Exactly. However, due to the underlying genomic instability and the resulting structural dysplasia, those precursor cells are fundamentally defective.
They just don't work.
Right. They undergo premature intramedullary apoptosis before they can ever fully mature and reach the peripheral circulation.
It's essentially mass cellular suicide in the marrow.
Yes. This concept of highly active but fundamentally ineffective hematopoiesis is what ultimately drives the chronic, debilitating clinical sequelae of the disease.
However, the diagnostic landscape becomes particularly challenging when you encounter what we might term the morphology negative diagnosis.
Yes, this is where the guidelines really lean into the molecular data.
Right. The guidelines explicitly acknowledge that less than 10% of patients will lack the requisite morphologic dysplasia.
Meaning the pathologist observes less than 10% dysplastic cells in any given lineage under the microscope.
Right. But these patients can still be definitively diagnosed with myelodysplastic syndromes if their molecular profiling reveals specific, highly predictive cytogenetic abnormalities.
That is a critical point for the practicing clinician. The absence of visual dysplasia does not exclude the diagnosis if the genetic data dictates otherwise.
So what are we looking for in those cases?
These defining cytogenetic abnormalities include monosomy 5, 7, or 13.
Okay.
They also include structural deletions of 5q, 7q, or 13q, or an isochromosome 17p, or a translocation involving 17p, or specific deletions of 11q, 9q, or 12p.
So if you identify one of those specific cytogenetic aberrations in a patient with unexplained persistent cytopenias, the diagnosis is established.
Absolutely. The genomic signature takes absolute precedence over the microscope.
But I want to push back on the clinical boundaries established by these classifications, specifically regarding the blast threshold.
Okay, let's hear it.
We know that the historic and honestly current blast threshold distinguishing myelodysplastic syndromes from acute myeloid leukemia remains rigidly set at 20%.
Correct.
However, we have this category of MBS IB2, which encompasses patients with 10 to 19% blasts.
Yes.
I struggle with this 20% cutoff in the clinic. If 20% is the definitive hard cutoff for defining acute leukemia, why do we see clinical pathways in literature suggesting that patients with 10 to 19% blasts are frequently managed and treated similarly to patients with acute myeloid leukemia?
It's a very valid frustration.
Right. It seems there is a significant clinical blur at that 20% threshold that complicates therapeutic decision-making. If I have a patient at 19% blasts, mathematically they're labeled as MDS-IB2, but biologically their disease is screaming acute leukemia. How are you navigating this gray area in your practice?
Well, you are highlighting the inherent limitation of applying rigid mathematical cutoffs to what is fundamentally a continuous, evolving biologic spectrum.
The disease doesn't care about our math.
Exactly. The 20% threshold separating myelodysplastic syndromes from acute myeloid leukemia is an arbitrary historical convention.
It was essentially made up for trials, right?
Yes, it was originally designed to standardize clinical trials and ensure uniform treatment protocols across different institutions. However, biologically, a patient with 19% blasts and a patient with 21% blasts likely share the exact same aggressive disease biology.
Driven by identical molecular derangements and subclonal architecture.
Precisely. Recognizing this continuum, Clinicians often manage patients in the MDS-IB2 category, those with 10 to 19% blasts with the same intensive urgency as acute leukemia.
Especially if they have other high-risk features.
Right, particularly if they exhibit high-risk genetic features, complex karyotypes, or rapidly progressive cytopenias that threaten immediate end organ function. The label is less important than the biologic momentum of the disease.
That concept of a biologic continuum is equally relevant on the opposite end of the disease spectrum, long before the blast count ever begins to rise.
Yes, the early-stage clonal states.
Right. This brings us to a clinical entity you will frequently encounter when working up unexplained anemia on the wards: clonal cytopenia of undetermined significance, or CCUS.
It's becoming incredibly common with broader sequencing.
It really is. As molecular sequencing becomes routine, you will frequently evaluate patients who present with unexplained, persistent cytopenias, and who, upon next-generation sequencing, are found to harbor somatic clonal variants commonly associated with myeloid malignancies.
We're talking about mutations in TET2, DNMT3A, or ASXL1.
Exactly. However, these patients do not meet the strict diagnostic criteria for myelodysplastic syndromes. They lack the requisite 10% morphologic dysplasia on their bone marrow biopsy, and they do not possess the specific defining cytogenetic abnormalities like monosomy 7.
So they fall into the CCUS category.
Right. We classify these patients as having CCUS. They exist in a precarious premalignant state.
Right.
While they do not have overt disease today, you must recognize that they require vigilant, ongoing hematologic monitoring.
Because they can progress.
Yes. Their risk of eventual clonal evolution and progression to overt myelodysplasia or acute leukemia is substantially elevated compared to the general population.
So we have established the stringent parameters for defining the diagnosis, whether through morphology or molecular signatures.
Right.
But a diagnosis alone does not tell you what happens to the patient tomorrow. The immediate subsequent step for the clinician is establishing the patient's prognosis.
You have to know where the disease is going.
You cannot formulate a rational, individualized therapeutic strategy without first understanding the anticipated trajectory of the disease. This requires moving directly from the World Health Organization 2022 diagnostic classification into the rigorous application of the revised International Prognostic Scoring System, or IPSSR.
The absolute gold standard for prognostication.
Yes. The IPSSR is the indispensable clinical tool that provides far more precise risk stratification than the original scoring system by deconstructing the patient's presentation into highly specific, weighted variables.
How many groups are there?
It defines 5 distinct risk groups: very low, low, intermediate, high, and very high. To place your patient into one of these groups, you must meticulously calculate a score based on 5 precise parameters derived from their initial bone marrow biopsy and peripheral blood counts.
Let us deconstruct those 5 specific variables because the exact mathematical calculation completely dictates the entire treatment paradigm.
It really does.
First, you evaluate the cytogenetic group, which the IPSSR stratifies into 5 tiers: very good, good, intermediate, poor, and very poor.
Give us an example of the extremes.
Sure. A very good karyotype might involve an isolated loss of the Y chromosome, which is fairly benign, while a very poor karyotype is defined by a complex karyotype with 3 or more distinct chromosomal abnormalities.
Extremely unstable.
Right. Second, you assess the bone marrow blast percentage, categorized strictly as less than or equal to 2%, greater than 2 to less than 5%, 5 to 10%, and greater than 10%.
Which heavily weights the score.
It does. The final 3 variables assess the severity of the patient's peripheral cytopenias. We look at the hemoglobin thresholds, categorized as greater than or equal to 10, 8 to less than 10, or critically, less than 8 grams per deciliter.
At which point they are profoundly symptomatic.
Exactly. Then we assess the platelets, stratified as greater than or equal to 100, 50 to less than 100, or a severe thrombocytopenia of less than 50,000 per microliter.
Again, high bleeding risk.
Right. And finally, we evaluate the absolute neutrophil count, scoring it based on whether it is greater than or equal to 0.8 or less than 0.8 thousand per microliter, which places the patient at significant risk for opportunistic infections.
The true precision of the IPSSR lies in its heavily weighted scoring system. It does not treat all cytopenias equally, and it heavily prioritizes the presence of high-risk cytogenetics and increasing bone marrow blast percentages.
So how do we use this final number?
Well, when you calculate the cumulative score from those 5 variables, you arrive at a specific numerical value. In the management of myelodysplastic syndromes, there is no number more critical than the cutoff score of 3.5.
3.5 is the magic number.
It is. This specific threshold serves as the definitive clinical dividing line between lower risk and higher risk disease, and the prognostic implications of a patient falling on one side or the other are remarkably stark.
Let's talk about the lower risk side first.
Right. Patients who calculate to a score of less than or equal to 3.5 are designated as having lower risk disease. For this cohort, the natural history of the illness is generally prolonged.
What are we looking at for survival?
The median survival for these lower-risk patients is 5.9 years. Their primary clinical burden is typically driven by the cumulative morbidity of chronic cytopenias, particularly the relentless fatigue and end-organ strain of profound anemia.
However, the moment a patient's calculated score crosses that threshold to greater than 3.5, their clinical reality changes instantly.
It's a completely different prognostic world.
They are designated as having higher risk disease. For these patients, the median survival plummets from 5.9 years to a mere 1.5 years.
A massive drop.
Right. The biology of the disease in the higher risk category is fundamentally different. It is no longer just a disease of ineffective cell production.
No, it's an active malignancy rapidly evolving.
Exactly. It is characterized by rapid clonal evolution, a high propensity for imminent transformation to acute myeloid leukemia, and a fundamentally abbreviated life expectancy.
Everything changes.
Every therapeutic decision you make, every medication you prescribe, hinges entirely on identifying which side of the 3.5 line your patient occupies.
Which is why the calculation has to be perfect.
But that rigid dichotomization at 3.5 raises a persistent clinical dilemma regarding the IPSSR intermediate risk category.
It's the intermediate gray zone.
Right. The intermediate category itself spans a range of scores from greater than 3.0 to less than or equal to 4.5. This means the intermediate category actually straddles that critical 3.5 threshold.
It crosses right over it.
When you are sitting in the clinic with a patient who mathematically scores a 3.0 and another patient who scores a 4.0, they are both technically intermediate on paper.
According to the strict IPSSR label, yes.
Yet biologically, they are crossing a massive prognostic threshold.
Yeah.
How do we operationalize this gray area? The guidelines suggest different pathways depending on whether they are lower risk intermediate or higher risk intermediate. But navigating this requires significant clinical nuance. How do you synthesize this intermediate risk designation into an actionable treatment plan?
The management of the IPSSR intermediate category is arguably one of the most complex and nuanced areas in daily hematologic practice. The most robust and defensible clinical approach is to meticulously split the intermediate category precisely at that 3.5 threshold.
So you just cut it in half.
Essentially, yes. If an intermediate patient calculates to a score of less than or equal to 3.5, you systematically manage them according to the lower risk treatment algorithms.
Focus on symptoms.
Exactly. Your clinical focus will prioritize symptom management, correcting the anemia, and minimizing the profound burden of transfusion dependency. Conversely, if an intermediate patient calculates to a score greater than 3.5, even if they are technically still labeled as intermediate by the system, you must rapidly pivot to the higher risk therapeutic algorithms.
Because their biology is high risk.
Right. Your focus must shift entirely away from mere symptom control toward altering the natural history of the disease. You must utilize disease-modifying agents to delay leukemic transformation and attempt to extend survival.
It is a critical distinction that dictates the entire trajectory of care. And as we apply this framework, we must also look toward the immediate future of prognostication.
Because the IPSR is not perfect.
Right. While the IPSSR remains the current, mandated gold standard for calculating risk, it's primarily based on clinical variables and traditional cytogenetics.
It ignores the molecular data we just discussed.
Exactly. It does not comprehensively account for the genomic paradigm shift we highlighted earlier, so the field is actively moving toward the Molecular International Prognostic Scoring System, or IPSSM.
The IPSSM is going to be a game changer.
It is. The IPSSM comprehensively incorporates specific molecular mutations like TP53, ASXL1, and RUNX1 directly into the mathematical risk algorithm.
Which makes logical sense.
It does. The IPSSM recognizes a crucial biologic reality. The presence of specific somatic mutations, even in the complete absence of traditional high-risk cytogenetics or elevated blasts, can profoundly accelerate a patient's disease and worsen their prognosis.
So a patient could look lower risk on the IPSSR but be very high risk molecularly.
Precisely. While the IPSSM currently requires further broad clinical validation across diverse patient populations before it entirely replaces the IPSSR in our standard guidelines, it represents the inevitable, necessary integration of molecular profiling directly into our prognostic tools.
Let us examine how this framework translates into clinical practice, starting with the therapeutic strategy for the group of patients identified by the IPSR as lower risk, those with a score of less than or equal to 3.5.
The lower risk group.
Right. For these patients, the dominant clinical battle is rarely an immediate threat of acute leukemic transformation.
You usually have years before that happens.
Exactly. Instead, the battle is fought against severe, highly symptomatic anemia and the resulting debilitating burden of transfusion dependence.
Which is a huge issue for quality of life.
And beyond just quality of life, chronic red blood cell transfusions are not a benign intervention.
They have real toxicity.
They absolutely do. They lead to progressive iron overload, which induces hepatic cirrhosis and restrictive cardiomyopathy. They lead to alloimmunization, making future cross-matching exceptionally difficult.
The blood bank hates that.
Oh, they despise it. And perhaps most importantly, they result in a profound deterioration in the patient's quality of life. The patient becomes tethered to the infusion center.
Every week or 2 weeks, they're in a chair getting blood.
Right. In this specific arena, however, we have witnessed a major therapeutic breakthrough with the introduction of novel targeted agents.
Which brings us to luspatercept.
Yes. This brings us to luspatercept, a medication that has fundamentally revolutionized the management of anemia in this specific patient population.
To understand why luspatercept is so effective, we really have to look closely at its pharmacology.
It's a very unique mechanism.
It is. Luspatercept is defined as a recombinant fusion protein that acts as a transforming growth factor beta, or TGF-beta, ligand trap.
A ligand trap.
Right. Its primary mechanism of action is highly specific. It promotes late-stage erythroid differentiation in the bone marrow. The profound efficacy of this agent was initially established and validated in the pivotal Medalist trial.
The Medalist trial was massive.
It was. This trial evaluated a highly selected population of patients who had the morphologic presence of ring sideroblasts and who were heavily dependent on red blood cell transfusions.
So these were heavily pre-treated transfusion-dependent patients?
Yes. The trial design compared luspatercept directly against a placebo, and the results were truly unequivocal. 38% of the patients treated with luspatercept achieved complete transfusion independence for a continuous period of greater than or equal to 8 weeks.
Compared to what in the placebo arm?
Compared to a mere 13% of patients receiving the placebo. This difference was statistically highly significant, with a p-value of less than 0.001.
That's incredible efficacy for that population.
And furthermore, the median duration of this transfusion independence was a remarkable 30.6 weeks.
30.6 weeks without needing a single unit of blood.
Right. Imagine a patient who has been tied to an infusion center every 2 weeks for years, suddenly getting their life and their independence back for 8 straight months.
That is the clinical magnitude of what the Medalist trial achieved.
It changed the standard of care for ring sideroblast patients.
It did. The Medalist trial successfully established luspatercept as a highly active, targeted agent for patients with ring sideroblasts. However, the subsequent COMMANDS trial expanded its clinical utility even further.
Right. The COMMANDS trial pushed it into the frontline setting.
Exactly. Fundamentally challenging and ultimately changing our traditional standard of care. The COMMANDS trial was a head-to-head phase 3 study that evaluated luspatercept in an erythropoietin-stimulating agent-naive population.
So they hadn't seen ESAs yet.
Right. These were lower-risk patients who were transfusion-dependent but had never received an agent like erythropoietin alpha. The trial was designed to directly compare the efficacy of luspatercept against that established standard therapy, erythropoietin alpha.
And what did the data show?
The data demonstrated clear, undisputed superiority for luspatercept. Specifically, 58.5% of the patients receiving luspatercept achieved the composite primary endpoint,
Which was defined as?
complete transfusion independence for greater than or equal to 12 weeks, with a concurrent robust hemoglobin increase of greater than or equal to 1.5 grams per deciliter.
That's a very rigorous endpoint.
Very rigorous. In stark contrast, only 31.2% of the patients receiving erythropoietin alpha achieved that same composite endpoint. Again, the statistical significance was profound, with a p-value of less than 0.0001.
So it basically doubled the response rate of the standard of care.
Yes, and beyond just the response rate, the durability of that response is what truly changes the patient's long-term management.
How long did the responses last?
The median duration of response for patients randomized to luspatercept was an impressive 127 weeks. Compare that to just 77 weeks for those receiving erythropoietin alpha.
Over 2 years of transfusion independence. That's life-altering.
Absolutely. From a clinical logistics standpoint, the administration is straightforward but requires precise ongoing hematologic monitoring by the physician.
Walk us through the dosing.
The starting dose of luspatercept is strictly 1.0 milligrams per kilogram, administered via subcutaneous injection every 3 weeks. Depending on the patient's hematologic response and their ongoing transfusion requirements, this dose has the potential for sequential titration up to a maximum of 1.75 milligrams per kilogram to optimize the hemoglobin trajectory.
But to truly understand how and why to deploy this medication effectively, we need a deeper physiologic explanation.
Yes, understanding the mechanism is key.
As physicians, we are very comfortable with the concept of using erythropoietin-stimulating agents to simply stimulate the bone marrow to produce more red blood cells. We use them routinely in chronic kidney disease, for instance.
Right, it's very standard.
So why is targeting late-stage erythroid differentiation with a TGF-beta ligand trap demonstrably more effective in these specific patient populations than simply stimulating the marrow with early-stage erythropoietin alpha? What exactly is the mechanistic failure of standard erythropoietin therapy in the context of this specific disease?
Well, to understand the clear superiority of luspatercept in this setting, we really must revisit the fundamental pathophysiology of ineffective erythropoiesis that defines the disease.
Go on.
When you administer an early-stage erythropoietin-stimulating agent, you are providing massive doses of exogenous erythropoietin to stimulate the proliferation of early undifferentiated erythroid progenitor cells.
Right, you're stepping on the gas pedal.
Exactly. But the central problem in myelodysplastic syndromes is almost never a lack of early progenitors. In fact, as we discussed with the cellularity paradox, the marrow is usually hypercellular and teeming with abundant early precursors.
So making more early cells isn't the solution.
No. The primary defect lies downstream in the maturation process. As these early precursors attempt to mature into functional enucleated red blood cells, they are exposed to a highly toxic, overactive inflammatory microenvironment within the bone marrow.
What's driving that toxic environment?
This hostile environment is driven largely by aberrant pathological signaling from the TGF-beta superfamily of ligands. This hyperactive signaling induces rampant premature apoptosis in the late-stage erythroid precursors.
So they die right before they mature.
Right. Therefore, aggressively stimulating the early stages with exogenous erythropoietin simply creates more precursor cells that are mathematically destined to undergo programmed cell death before they ever mature.
So if I am using an erythropoietin-stimulating agent in this scenario, it is akin to accelerating a car that is driving straight into a brick wall. I am just creating more traffic piling up at the site of the apoptotic block. The cells are dying off right before they cross the finish line into the peripheral blood.
That is an excellent analogy. You are merely exacerbating the intramedullary death. Luspatercept, however, addresses the actual bottleneck.
By removing the brick wall.
Exactly. As a recombinant fusion protein acting directly as a ligand trap, it circulates and physically binds to these aberrant TGF-beta superfamily ligands.
So it sweeps them up.
Right. By sequestering these ligands, it specifically inhibits the downstream SMAD23 intracellular signaling pathways within the erythroid precursors.
Which turns off the death signal.
Yes. By neutralizing this pathological signaling cascade, luspatercept effectively turns off the massive apoptotic signal in the late stages of red cell development. It dismantles that brick wall. It prevents the premature death of these cells, allowing the late-stage precursors to finally differentiate, mature, and nucleate, and enter the peripheral circulation as fully functional, oxygen-carrying erythrocytes.
That's brilliant.
This precise mechanistic action is why it succeeds where traditional erythropoietin-stimulating agents fail, particularly in patients who already have high endogenous levels of erythropoietin.
How high are we talking?
Specifically, those with a serum erythropoietin level greater than 200 milliunits per milliliter. In these patients, their endogenous early-stage stimulation is already maximized. Their kidneys are producing immense amounts of erythropoietin in response to the anemia.
So giving them more is pointless.
Exactly. The therapeutic intervention must therefore bypass the early stages and specifically target the late-stage apoptotic block.
So luspatercept is heavily preferred here.
Yes. While luspatercept is heavily preferred and most efficacious for patients harboring SF3B1 mutations or those with the morphologic presence of ring sideroblasts, the data from the COMMANDS trial clearly demonstrates its efficacy across various subtypes, including non-ring sideroblast patients, provided we are targeting the correct pathophysiologic mechanism.
Now let's switch gears. Consider the patient who calculates to an IPSS-R score of 4.5.
The higher-risk patient.
Right. We must now pivot our clinical focus to the patients who occupy the other side of that critical cutoff.
Because symptom management is no longer enough.
Not at all. For patients with higher risk disease, symptom control and achieving transfusion independence are entirely insufficient clinical endpoints. The objective of our medical intervention shifts dramatically.
What's the new goal?
The goal is no longer just improving quality of life. The goal is to fundamentally alter the highly aggressive trajectory of the disease, purposefully delay the inevitable progression to acute myeloid leukemia, and attempt to extend overall survival.
We're trying to buy them time.
Exactly. And in this high-risk space, the absolute cornerstone of medical therapy relies on the deployment of hypomethylating agents.
The HMAs.
Right, specifically azacitidine and decitabine, which have been firmly established as standard first-line therapies.
Yeah.
To understand the magnitude of their clinical impact, we must rigorously analyze the pivotal AZA-001 trial.
The defining trial for this class.
It is. This phase 3 trial evaluated the use of azacitidine, administered at a strict dose of 75 milligrams per square meter daily.
Given for 7 days, right?
Yes, given via subcutaneous injection for 7 consecutive days every 4 weeks. When compared against conventional care regimens, which included best supportive care, low-dose cytarabine, or intensive chemotherapy azacitidine, demonstrated a profound and highly significant survival advantage.
The survival data from the AZA-001 trial is literally the foundation upon which we build our high-risk treatment algorithms today.
Give us the numbers.
The median overall survival for patients receiving azacitidine was 24.5 months, compared to only 15 months for those managed with conventional care.
That's almost a 10-month improvement.
Yes, which yielded a hazard ratio of 0.58. That translates to a massive 42% reduction in the relative risk of death.
And the p-value.
The statistical power behind this was undeniable, with a highly significant p-value of 0.0001. Furthermore, the overall response rates were markedly improved.
What were the response rates?
Patients receiving azacitidine achieved complete or partial hematologic responses at a rate of 29% compared to only 12% in the conventional care arm.
So it established azacitidine as the absolute benchmark.
It did. This trial established azacitidine as the definitive benchmark for higher-risk disease. However, when we evaluate the corresponding phase 3 data for the other primary hypomethylating agent, decitabine, we observe a nuanced and somewhat conflicting clinical picture that requires careful interpretation.
That conflicting data is crucial for physicians to understand when selecting an agent on the wards.
Very crucial.
In its phase 3 trials comparing intravenous decitabine against best supportive care, decitabine demonstrated similar overall response rates to those seen with azacitidine.
So the response was there.
Yes, the response rate was similar. However, critically, it failed to demonstrate a statistically significant overall survival advantage.
Which is a huge distinction.
It is. The median overall survival for patients treated with decitabine was 10.1 months, compared to 8.5 months for those receiving best supportive care.
Only a month and a half difference.
Right. The hazard ratio was 0.88, with a p-value of 0.38, meaning the observed survival benefit does not reach statistical significance.
So it didn't formally prove survival benefit.
Exactly. But despite this lack of a demonstrated overall survival benefit in the phase 3 setting, decitabine remains firmly established and endorsed by the guidelines as a standard first-line option alongside azacitidine.
Right, which we will get into.
We will. But beyond the specific choice of agent, the most critical concept for physicians to understand when managing patients on any hypomethylating agent is the pharmacokinetic and pharmacodynamic time to response.
Yes. The concept of time to response cannot be overstated because misinterpreting it leads to catastrophic clinical errors.
Explain why.
These hypomethylating agents do not act like traditional, highly toxic cytotoxic chemotherapy. They do not immediately ablate the malignant clone and induce rapid marrow aplasia.
They don't just nuke the marrow.
No. Their mechanism of action relies on the gradual cell cycle dependent hypomethylation of DNA. As the cancer cells divide, the drug incorporates into the DNA and irreversibly binds DNA methyltransferase enzymes.
Which depletes those enzymes over time.
Exactly. This gradual depletion of methyltransferases leads to the progressive hypomethylation of the genome. This, in turn, leads to the re-expression of critical tumor suppressor genes that the cancer had previously silenced via epigenetic hypermethylation.
So it's turning the good genes back on.
Right. Once those tumor suppressor genes are turned back on, the cells can resume normal differentiation and undergo appropriate apoptosis. Because this epigenetic modification is a slow, cumulative process that requires multiple cycles of cellular division, the median time to observe any meaningful clinical response is 2 to 3 months.
I often explain this mechanism to residents using a specific analogy.
Oh, let's hear it.
Think of the patient's critical tumor suppressor genes as vital software programs that the cancer has maliciously locked behind a complex password using DNA methylation.
I like that.
As acididine and decitabine do not take a sledgehammer and destroy the entire computer, which is what traditional cytotoxic chemotherapy does.
Right.
Instead, these agents act slowly, systematically hacking the password. They gradually unmethylate the DNA, cycle by cycle, to turn those essential suppressor genes back on.
It takes time to hack the code.
Exactly. That is exactly why it takes 4 to 6 months to see a definitive response.
Yeah.
You are waiting for the cellular software to completely reboot and reestablish control over the marrow.
That analogy perfectly captures the epigenetic mechanism. You are reprogramming the malignant clone, not just destroying it.
And patience is key.
It is. Because of this delayed response kinetic, you must commit the patient to at least 4 to 6 consecutive cycles of therapy before you can accurately and fairly assess its clinical efficacy.
You can't just stop after 1 month because the counts are low.
No. Discontinuing the drug after 1 or 2 cycles because the cytopenias haven't improved or because they have temporarily worsened, which is highly common, is a profound clinical error.
It's the worst thing you could do.
It deprives the patient of the drug's potential long-term benefit, just as the epigenetic reprogramming is beginning to take effect.
That delayed kinetic requires meticulous patient counseling and significant clinical fortitude from the physician.
You really have to hold their hand through it.
You do. You are often managing profound therapy-induced cytopenias during those initial 2 to 3 months before the bone marrow finally begins to recover and demonstrate clonal suppression.
Right. It gets worse before it gets better.
You will be managing febrile neutropenia, prescribing prophylactic antimicrobials, and providing massive transfusion support while you wait for the drug to work.
And you just have to stay the course.
But let us return to the comparison between the two specific agents. If intravenous decitabine failed to show a significant overall survival advantage in its phase 3 trials compared to best supportive care, and as acididine clearly demonstrated a nearly 10-month survival benefit in the AZA001 trial.
Why use decitabine?
Exactly. Why is decitabine still considered a standard interchangeable option in clinical practice? What specific clinical utility does decitabine offer today that justifies its continued use as a first-line therapy for these higher-risk patients?
Well, the sustained role of decitabine in our modern therapeutic armamentarium is heavily driven by recent, highly innovative advancements in its pharmacological delivery.
The Oriform.
Yes. These advancements offer immense, tangible, practical benefits for the patient. While the historical intravenous administration of decitabine may not have shown the same overall survival benefit as acididine in phase 3 trials, we now have access to a highly effective oral formulation.
Oral decitabine cedazuridine.
Exactly, also known as AFTX 727. Cedazuridine is a potent inhibitor of cytidine diminase.
And what does that enzyme do?
That's the primary enzyme located in the gastrointestinal tract and liver responsible for the rapid degradation of orally administered decitabine. By effectively neutralizing this enzymatic breakdown, cedazuridine allows the oral formulation of decitabine to be absorbed intact.
So it actually reaches the blood.
Right, achieving systemic exposure profiles in an area under the curve that are completely pharmacokinetically equivalent to those achieved by traditional, continuous intravenous decitabine infusions.
The fact that cedazuridine can protect oral decitabine in the gut completely changes the quality of life for these frail patients.
It's a huge win for them.
It is a monumental shift from a logistics standpoint.
Yeah.
Recall the demanding acididine dosing schedule from the AZA001 trial, 75 milligrams per square meter, administered subcutaneously for 7 consecutive days, every single month.
That's a brutal schedule.
It requires the patient to travel to the oncology infusion center 7 days in a row, including over the weekend. That imposes a massive logistical, financial, and physical burden on a population that is already elderly, frail, and heavily symptomatic from their cytopenias.
Exactly. The oral decitabine-cedazuridine combination provides a highly active, disease-modifying epigenetic therapy that the patient can take safely at home.
They just take a pill.
Right. Entirely bypassing the infusion center and minimizing healthcare-associated exposures. This established equivalence in systemic exposure, combined with the profound quality-of-life advantage of oral administration, firmly cements its position as a standard first-line option.
Which makes perfect sense.
Additionally, as we look to the horizon of high-risk management, we are observing highly promising emerging clinical data regarding the combination of hypomethylating agents, both as azacitidine and decitabine, with the potent BCL2 inhibitor venetoclax.
Venetoclax has been huge in AML.
Yes. While venetoclax combinations are firmly established in acute myeloid leukemia, they are currently still under active, rigorous investigation in myelodysplastic syndromes.
Are we seeing good data?
We are. These combinations are showing significant potential for inducing rapid and remarkably deep cytoreduction, achieving blast clearance much faster than hypomethylating agents alone.
Which is key for getting them to transplant.
Precisely. This rapid clearance is particularly valuable as a bridging strategy to reduce the leukemic burden safely and effectively before proceeding to allogeneic stem cell transplantation.
That concept of bridging brings us to the ultimate and undeniably the most complex therapeutic intervention in our clinical algorithm.
The transplant.
Right. Even with the demonstrated successes of hypomethylating agents like azacitidine extending median survival to 24.5 months, the reality is that the median survival for patients with higher risk disease remains alarmingly short.
Roughly 2 years.
Exactly. Therefore, for every eligible patient you evaluate, you must rigorously and aggressively evaluate the feasibility of the only therapy with true curative intent available for myelodysplastic syndromes: allogeneic hematopoietic cell transplantation.
It's the only potential cure.
The initial step in this process is accurately defining the appropriate candidates. According to the current consensus guidelines, allogeneic transplantation should be strongly and immediately considered for patients with higher risk disease.
Which means the IPSS intermediate high or very high risk.
Right, specifically when their calculated score crosses that critical threshold and is greater than 3.5.
While higher-risk patients are the primary candidates, we must also consider the role of transplantation for carefully selected lower-risk patients.
Oh, really? Even lower risk?
Yes, a lower-risk designation is not an absolute contraindication to transplant.
Under what circumstances?
Well, if a patient mathematically falls into the lower risk category but presents clinically with severe life-threatening cytopenias that are refractory to targeted agents, or if they possess poor risk genetic features that strongly predict rapid progression despite a currently low blast count.
Like a bad molecular profile.
Right. Or if they have an exceptionally high and unmanageable transfusion burden causing rapid iron overload, they may absolutely warrant early transplant evaluation.
What about age? This is an older population.
Yes. Over the last decade, the eligibility criteria for transplant have evolved significantly. Historically, advanced chronological age was a strict, impenetrable barrier to transplantation. Today, however, transplant candidacy is routinely and safely considered for patients up to at least 75 years of age.
That expansion into the older demographic is crucial, considering the median age of diagnosis for this disease is over 70.
We couldn't cure anyone if we stopped at 65.
Right. We're routinely transplanting septuagenarians now, provided their physiologic performance status is excellent and their comorbidities are minimal.
Which we quantify using tools like the Hematopoietic Cell Transplantation Comorbidity Index.
Exactly. This remarkable expansion into older, frailer patient populations has been made possible almost entirely by the development and optimization of reduced-intensity conditioning regimens.
The RIC regimens.
Yes. Unlike historical myeloablative conditioning, which relied on massive, highly toxic doses of systemic chemotherapy and total body irradiation to completely obliterate the recipient's marrow.
Which would kill an older patient.
Absolutely. Reduced-intensity conditioning relies far less on upfront cytotoxic therapy.
What does it rely on?
Instead, it relies predominantly on the potent immunologic phenomenon known as the graft versus leukemia effect.
Where the new immune system fights the cancer.
Exactly. The newly engrafted donor immune system actively recognizes and eradicates the residual malignant clone.
The execution of an allogeneic stem cell transplant in a patient with this disease requires a meticulous, individualized pre-transplant strategy, specifically focusing on the critical need for disease cytoreduction.
You have to get the blast down first.
You cannot simply take a patient with 15% blasts in their bone marrow and proceed directly to the conditioning regimen.
Why not?
Because the relapse risk is astronomical. The established clinical consensus firmly mandates the absolute necessity of cytoreduction to drive the bone marrow blast percentage below 5% prior to initiating the transplant protocol.
So less than 5% is the target.
Achieving this specific morphologic remission state significantly reduces the risk of post-transplant disease relapse, which is the primary cause of transplant failure.
How do you get them below 5%?
That's the challenge. The guidelines explicitly acknowledge that the optimal induction strategy to achieve this sub-5% threshold remains highly debated and undefined. Clinicians must individualize the approach.
What are the options?
You must choose between utilizing hypomethylating agents like azacitidine or decitabine, which are generally less toxic but slower acting and may require months to achieve blast clearance, versus utilizing intensive AML-style induction chemotherapy, which provides rapid cytoreduction but carries significant immediate morbidity and mortality risk, particularly in older patients.
It's a delicate balance.
It really is.
Recent prospective trials and large registry analyses have firmly confirmed the long-term survival benefits of pursuing allogeneic transplantation in higher-risk patients when compared to continuous non-transplant approaches like indefinite azacitidine therapy.
It's undeniably better for survival.
However, when we evaluate the specific outcomes of transplantation in the literature, we must acknowledge a massively wide statistical variance. The reported 5-year overall survival rates post-transplant range dramatically from 0% to 94%.
That is an enormous statistical strike.
It's massive. This vast range is heavily dependent on a multitude of pre-transplant variables. Specifically, survival correlates tightly with the patient's age, their IPSSR category precisely at the time of diagnosis, the presence of specific, highly adverse cytogenetic abnormalities like a monosomal karyotype, and their pre-existing organ health.
So many factors at play.
Right. And even with an optimal pre-transplant cytoreduction strategy in a perfectly matched donor, disease relapse remains the single greatest barrier to long-term transplant success.
Relapse is the enemy here. Because relapse is the primary threat, the field is actively investigating aggressive post-transplant strategies to monitor for and combat microscopic measurable residual disease.
What kind of strategies?
These strategies include the preemptive administration of prophylactic donor lymphocyte infusions for patients identified as having the highest risk of relapse.
Giving them an extra immune boost.
Right. Or the maintenance use of low-dose hypomethylating agents post-transplant to sustain the epigenetic suppression of the clone and augment that graft versus leukemia effect.
I want to circle back to the World Health Organization, two genetic categories we discussed at the very beginning of this clinical review.
The molecular categories.
Yes. We noted the creation of the highly specific, very poor risk category of myelodysplastic syndrome with biallelic TP53 mutation. We established that this mutation is characterized by profound genomic chaos and that these patients fail to respond durably to standard hypomethylating agents.
Great.
What happens to this specific cohort of patients, those with biallelic TP53 mutations, when they receive an allogeneic stem cell transplant? Does the potent immunological mechanism of the donor's graft versus leukemia effect manage to overcome the profound genomic instability driven by the complete loss of the TP53 tumor suppressor function?
That question cuts directly to the heart of our most significant unresolved clinical challenge in myeloid malignancies today.
It's the big question.
As clinicians, we must face the grim, objective clinical reality regarding this specific genetic subset. Patients harboring a biallelic TP53 mutation possess a notoriously poor prognosis that persists even with the application of allogeneic stem cell transplantation.
So transplant doesn't fix it.
No. Unlike many other high-risk genetic lesions or complex karyotypes that can eventually be effectively neutralized by a robust graft versus leukemia effect, the complete biallelic loss of TP53 function creates a cellular environment characterized by such rampant, unchecked genomic chaos and profound chemoresistance that even a fully engrafted, highly active donor immune system frequently fails to control the disease.
The cancer just outpaces the immune system.
Exactly. The relapse rates post-transplant for this specific population are exceptionally high, often occurring within the first 6 to 12 months, and long-term overall survival remains devastatingly dismal.
So what do we do for them?
This harsh reality underscores a critical point in our modern management algorithms. Because our standard therapeutic pathways, including our only curative modality, largely fail this specific demographic, patients definitively diagnosed with myelodysplastic syndromes with biallelic TP53 mutation must be aggressively prioritized for immediate clinical trial enrollment.
Standard care isn't enough.
We cannot rely on standard hypomethylating agents or standard transplant protocols to significantly alter their trajectory. Their care must focus on novel, investigational cellular therapies, advanced targeted agents, or macrophage immune checkpoint inhibitors whenever accessible.
Well, this concludes our exhaustive clinical journey through the modern, highly complex management of myelodysplastic syndromes.
We covered a lot of ground today.
We did. We have traced the complete evolution of the diagnostic pathway, moving definitively away from a historical reliance on pure microscopic morphology toward the necessary integration of complex molecular and genomic markers, as strictly mandated by the World Health Organization 2022 update.
The paradigm shift is real.
It is. We have thoroughly examined the meticulous process of risk stratification, emphasizing the critical importance of triaging your patients based on the IPSSR 3.5 cutoff to differentiate lower risk from higher risk disease trajectories.
That 3.5 line dictates everything.
For those lower risk patients, we analyze the targeted deployment of disease-modifying agents, like the TGF-beta ligand trap luspatercept, to overcome apoptotic blocks and achieve vital transfusion independence.
Giving them their quality of life back.
Right. And for the higher risk populations, we detailed the strategic long-term use of hypomethylating agents such as azacitidine and decitabine to epigenetically delay leukemic progression, and we rigorously evaluated the complex eligibility criteria, the necessary preparatory cytoreduction strategies, and the highly variable outcomes associated with allogeneic stem cell transplantation.
As we conclude, I want you to consider the profound implications of the molecular biology we have discussed today. As genetic markers, particularly defining mutations like TT53, SF3B1, and ASXL1, increasingly dictate both the fundamental classification of the disease and the anticipated response to targeted therapies, frequently superseding the importance of visible cellular dysplasia entirely. And as we increasingly manage patients with 10 to 19% blasts utilizing intensive treatment algorithms originally designed exclusively for acute myeloid leukemia.
Where is this leading us?
We must ask ourselves a profound question regarding the future of our clinical taxonomy. Will the morphologic term myelodysplastic syndromes eventually become entirely obsolete? Will we soon rely exclusively on precision molecular and genomic classifications to define the entire biologic spectrum of myeloid neoplasms, leaving the microscope behind entirely?
Thank you for joining us for this review of the source material.